everybody. There we go. Setting up the live.
Recording in progress.
Great. Awesome. Lots of people have jumped on. Well, hi everyone. Welcome to the Homebirth New South Wales Midwives Q&A. I had a feeling that this was going to be a very popular event this week. My name's Emma Burke. I'm a birth and a postpartum doula and birth photographer based in Sydney. I'm also a volunteer for Homebirth New South Wales, looking after all of our members. And we have two amazing midwives here with us. We've got Melanie Jackson and Ashlee Anslow. I have a little housekeeping to read through, so I'll go through that and then I'll get our midwives to introduce themselves. So welcome to our Homebirth New South Wales webinar. We're celebrating Homebirth Awareness Week this week, and we're so excited to be hosting a week of incredible virtual events for all of our followers to give you insights into various aspects of planning for your upcoming birth and motherhood journey. You can see all of the events that we've done throughout the week on our website on homebirthnewsouthwales.org.au and clicking on the events tab. Homebirth New South Wales is a not-for-profit organisation run by committed, passionate volunteers who are dedicated to educating and supporting women who wish to give birth at home. Our mission is to enable improved accessibility and affordability to women to home birth services in New South Wales and Australia-wide for all families that want it. Homebirth New South Wales provides families information and support in their pregnancy and birth journey, including linking women to an incredible list of home birth midwives and other services, including doulas and birth photographers who support home birthing families all the time. Homebirth Awareness Week is an international event where we aim to shine a light on the safety and the incredible benefits obtained by birthing at home and support those who are seeking home birth by welcoming them into our local and statewide communities. Home birth is a very safe option for low-risk women who want to have a more natural birth and reduce the risk of birth interventions. Birthing at home with a midwife in attendance is as safe as birthing in a hospital for mother and baby, but also reduces the risk of maternal morbidity. Home birth reduces the chances of severe perineal tearing, cesarean sections, instrumental births, inductions, epidural use, and increases the likelihood of a physiological vaginal birth, typically while providing you with the comfort and safety of your own home and a known to you skilled care provider in our fabulous midwives. As you'll see in the events of this week, there are many positives to birthing at home, so hopefully these sessions will help provide more information for home birthing families and those interested in home birth. Please don't forget to enter our raffle. For just $20, you can be in the running to win one of 3 huge prize packs, which each is valued at about $1,500. They include birth photography packages, doula training, postpartum meal packs, lactation consults, childbirth education, books, and lots more. You can find all the information on our website, which is homebirthnsw.org.au. We really hope you enjoy the sessions, and please feel free to type any comments or questions into the chat box. And as I said, we'll get to them in the last part of the webinar. Also, just by being here today, you're able to access a $50 discount voucher from Active Truth, who is our sponsor for our Home Birth Awareness Week events. So thank you to Active Truth, who've been an ongoing supporters of Home Birth New South Wales and create incredible activewear, enabling more representation, more confidence, more options, and more respect. So there you go. So I will just introduce both Melanie and Ashlee. Melanie, would you like to go first and maybe introduce yourself and possibly explain how you got into private practice?
Sure. So yeah, hi, I'm Melanie Jackson. I am a private midwife in Australia and closer to Sydney in the Blue Mountains. I've been a private midwife for 13 years And my whole midwifery career has been in home birth. I haven't had a career in hospital ever. I have 2 children. They were both born at home. I'm also a research midwife, which came out of my PhD research, which was birthing outside the system. And yeah, I think that's me.
You. Awesome. Thanks, Melanie. And Ashlee.
Yeah, hi, my name's Ashlee Anslow, and I am a newly privately practicing midwife. So I live about 2 hours west of Sydney, and Mel and I work together and back each other up for birth. I've been in the hospital system for the last 12 years, but over the last 12 months, I've fully transitioned into privately practicing midwifery. I have 3 children. I had my first child through a caseload practice within the hospital, and then I was looking at having a home birth for my second, and I had twins. So we changed a few plans, but that was okay because it was a really good experience. So.
Wow, congratulations on your twins. What amazing effort. So maybe I'll start with you with this question, Ash, because you do have that experience with both the hospital system and obviously home birth. Even though you're new to home birth, 12 months of experience, I'm sure you have quite a lot that you've supported so far. So the question is, what are some of the main differences between a home birth with a private midwife and a hospital-run home birth program?
Accessibility. I mean, access to privately practicing midwives is a huge issue around the country and in other countries as well, partly because of the cost that is involved. But while it's great that we've got some publicly funded hospital programs, there are often quite strict restrictions involved. So people are often not guaranteed that they're going to actually have that home birth option until about 36 weeks gestation, and there's a whole bunch of hoops that they sort of have to jump through to be able to do that. So that's one of the big ones, and that very small restrictions that can impact on people that wouldn't otherwise with a privately practicing midwife.
Yeah, for example, somebody might be restricted by their BMI in the hospital system, whereas for a private practice midwife, they wouldn't have concerns with that. Is that correct? Yeah.
Yeah. Look, each different midwife will probably weigh up their own experience with different issues, and that's something for women to discuss, those sorts of things. But there is generally a lot more flexibility with privately practicing midwives compared to the hospital-based programs. That being said, particularly because of the cost involved, I have a bit of a background in public health sort of stuff. I like to think that publicly funded home birth would be something that everyone could access, although that may be wishful thinking a little bit, but yeah.
So Mel has actually asked, and this is relevant to what we were just speaking about, is so no twins for a home birth.
Well, yes. I want to speak to this one, Ashlee.
Well, look, there may be some privately practicing midwives that would. For me, obviously, I am aware of all of the benefits of physiological birth. Twins is a little bit more complicated, and for me, as much as I have seen some really wonderful photography of some lovely home birth twins birth, that wasn't an option that I chose in that situation. Obviously, I'm a big supporter of home birth. That's what I'm, doing all the time now. But and I had 2 really, really skilled obstetricians attend my birth. I had a really good experience around informed consent. People kind of were waiting to hear what my decision was around how I was approaching my birth. So there was no coercion or anything like that involved. But for me, I chose not to give birth to twins at home.
Really, of the midwives that I know here in Sydney, there's no one who would do twins at home as private midwives here in Australia, as far as I'm aware. There used to be a few very skilled wise midwives who would do twins at home, but the climate here in Australia for home birth midwives at this point, probably for the last 10 years or so, can be pretty hostile. So private midwives are always looking for ways to avoid being reported to our registration body and all kinds of things. And twins is really outside a lot of midwives' scope and really best managed by a really skilled healthcare provider. And private midwives and most midwives have never really had an opportunity to upskill in a way to adequately care for women giving birth with twins if they have a complication. So we do tend to not do twin births at home.
This is that one. So in your experience, and this is just a question from me, Ash, did you find that it was possible for you to still achieve a physiological birth with twins in the hospital?
So I guess it really becomes dependent on the medical situation. So my particular experience was I had a twin that was growth restricted. I chose to be induced. Mind you, I had a very subtle induction experience compared to, what some induction experiences can be. I successfully had a vaginal birth for both twins. I had my second twin present as a compound presentation. So there were a few maneuvers involved in that, and he was born as a footling breech. So kind of cool, but also I'm a calm birth educator as well, and with a lot of those sorts of antenatal education programs, you learn a lot of things around the relaxation response. And actually it was my ability to remain completely calm that actually enabled me to have a vaginal birth for my second twin, because of the position that he was presenting in and the things that needed to happen there. But that's where I was grateful that I was in a position where I had two extremely skilled obstetricians in that. So I felt like I was in completely safe hands, and they were good decisions. It wasn't a physiological birth the way I experienced with my daughter, but I feel that between Mel and my birth experiences, we kind of are able to identify with a lot of different experience that clients may encounter. So that's still helpful.
Yeah, that's incredible. Brilliant story. So you may have touched on this with the previous question that I asked Ash, but for publicly funded home birth, is it difficult to get in or get a place, or can you just mention that it's your preference and they'll accommodate you?
That is quite difficult. I worked at Randwick just prior to their publicly funded home birth model coming in. I believe some of the things had changed a fair bit there, but you kind of had to be in the care of a specific group practice to be able to access it. Frequently group practices will book out by, and even now I'm experiencing, had at the point of getting July inquiries for next year. So, you're talking about the people who are switched on and educated enough to know that they need to access that maternity service and get their name down. And then that's all planning that happens. You can't kind of rock up at 12 weeks gestation, have a booking visit, be told that you can have a publicly funded home birth and go, oh yeah, that sounds good. Has to happen way before that most of the time.
Yeah, I mean, it's exciting that there would be some demand for it, but I'm sure that the capacity of the hospital system would be quite small.
Yeah, although I did see last week, I think Randwick celebrated their 100th home birth since the program started, which Cheryl Slattery set up. So that's a massive achievement for them.
Brilliant. So I might direct this question to you, Melanie. what are some common labouring positions that you would suggest to a woman? And the way that I interpreted this was not with regards to trying to reposition baby, but more so during the labour to try and make her more comfortable. Are there sort of some positions that you would usually go to straight away?
In terms of positioning, I would encourage women to go with their intuition. So basically, actually early on in my research career, I was part of a birth position study, which basically my job was to go to heaps of births and just record what women did during their labours. And a lot of them were home births. And as I watched women labour and we put all the information together later, what we noticed is that in early labour, women have a tendency to want to walk around and move a lot more. And the deeper they get into labour, the lower they get to the ground. And so, and that's just that's a physiological process. And that's something that women are wise enough to intuitively know what to do during their labour and birth. So I think the best position for women during labour is whatever is most comfortable and whatever you feel like you want to do. I've never seen a client of mine who's having a home birth actually consciously go and lie on the bed in order to labour. Every time a woman ends up lying down, often a contraction starts and the first thing I want to do is get up. So it's certainly not a physiological position to be lying flat on your back during labour. I have seen women very comfortably lie on their side, and certainly in the water birth, you can move any way you like. So yes, I don't encourage any particular position unless we're trying to intervene in some way, in a sense of, if the baby needs assistance, or if we've noticed something, we might suggest a position that might be easier for the woman to push her baby out, like a squat or a what we call prayer pose, and all kinds of different things. But I would encourage women to go with their intuition, because actually they'll do what's most comfortable.
Yeah. I usually would explain to women, like in the same way that your cat or dog would find the perfect spot on their bed, or the same way that you roll around in bed to find that nice cozy position. It's the same in labour. You just instinctively move to find those positions. So thank you. That's so interesting, the research. I love that. You got to witness birth and record the positioning that they went into. How funny. So I'm not sure how, this question is actually, what do you love / hate about home birth? I don't know if there's really anything to hate, but maybe you could talk about some of the things that you love versus some of the challenges that arise with being in private practice and having obviously a caseload of women to support. Melanie, do you want to go first?
Sure. So is that about my work personally as a midwife, what I find amazing and challenging?
Yes.
Okay. Well, I'll start with, let's just do it all together. Okay. Amazingly, when you're a private midwife, you actually have an incredible amount of control over what you do in your week. So a lot of people think, there's no way I could be on call and do that and not having to constantly be available to women. But actually, I think that midwives who work in a hospital are more trapped by their roster than we are as private midwives, because a lot of the timing of seeing clients, we can choose that. The only thing we can't choose is if a woman suddenly develops a complication or goes into labour, we're on call for all that as well. So I love the flexibility. I actually homeschool my kids and my husband works from home. And so being able to do all of that as well as being a private midwife is something that I really love. I love being able to work in a way that that's not morally distressing on my knowledge as a midwife, because I'm actually caring for women in an evidence-based way and in a way that they want, and not in a way that's imposed upon them by a system. So we don't work with policies, and there's nobody over our shoulders asking us to do things that the woman doesn't want to do. A challenge with that, I guess, is that we have to be really on the ball with what the current evidence is, and actually take initiative with our own ongoing training and understanding to make sure that we're actually up to date and knowledgeable and skilled enough to manage what we need to manage at home. So although that's also amazing because we can pursue any resources that we feel valuable, and we're not sort of fed that information by our employers. What else? Gosh, there's thousands, but I think that working as a private midwife, you understand birth in a way that you'll never be able to understand it when you work in a hospital. And most of my learning is done by just watching what birth is, because we don't learn what labour and birth is in hospitals, because very few women actually get an uninterrupted physiological birth. So being a home birth midwife, we don't really have the option to do a lot of intervention because we're at home, and there's, we don't have all of that complex equipment that might be used to intervene. So private midwives really hold on to information about what normal physiological birth is and what it looks like. And because of that, we know what abnormal looks like, and we know when to move into hospital and when to stay home. And I can just see a question up there. What's my transfer rate? It's about 10 to 15% transfer rate. So 85 to 90% of women who plan to give birth at home would give birth at home. And not all of those transfers are emergencies. So yes, I think, Ashlee, have you thought of anything? Because she's actually just, recently come out of a hospital system, but yeah.
I should share that so I got actually quite close to giving up my midwifery registration because of that moral distress that Mel talked about. And it was Mel and a few others in the area that sort of helped push me a little bit. And she basically said, why don't you come and second for this home birth? And the first one that we did at home, she was just grinning at me. I probably couldn't wipe the smile off my face. Look, I had a really good experience. I worked for quite a few years in a caseload practice that was a really supportive birth model, and did a really fantastic job. And that was a really formative process for me. But I really felt that moral distress about not being able to actually practice that way. So to be able to witness that normal physiological birth, and yes, sometimes we have to act on things, but for the vast majority of time, our births are like that. So for me, that the vast majority of my practice is actually being able to witness that normal physiological birth, seeing that transformation of women becoming mothers. And yeah, I would not go back at all. The hardest thing is probably I don't find being on call 24/7 difficult necessarily. With children though, that can be a little bit of a handful. My twins are now 4.5, so it is something that's getting a little bit easier, but that's probably it's just part of the job and just learning to negotiate that side of life. Mel and I also have livestock, which can be demanding at times, so sometimes there's a little bit of juggling.
Ashlee and I are farmers on the side. Secret little hobby of ours.
So we're like secretly, it's like, do I need to milk the goats or the cow before I leave to go to this labour? So that there's that.
That's hilarious. I didn't know that about you guys. And midwife and farm. At least you've got all the skills, if one of your animals births. If that's the correct terminology. So Ashlee, you haven't been in a private practice setting, for long enough probably, but I'll just direct the question at you with what's your transfer rate at the moment?
About the same as Mel, because we're attending the same births together. I've experienced 2 women get transferred, one for birth and one afterwards. They were both home 24 hours later with care resumed at home. So it was a pretty good experience.
And that's a whole year of births.
Yeah.
That we've had
between both of us.
Yeah. I think that there is, I suppose, some kind of misconceptions about home birth transfer out there, and my experience has always been it's a very calm, informed process. Do you want to, either of you can put your hand up, but did you want to speak to, when a transfer is required, that sort of cascade of events and what goes on, just to, I guess, dispel some of the myths that it's like, grab the bags, the ambulance, and, like chaos?
We can. So it depends what it's for. So as I said before, not all transfers are emergencies. And so probably we actually probably drive in our own cars more often than we call an ambulance. And so those transfers in labour, for example, probably the more common non-emergency transfer is women who are just experiencing a really long labour, super slow progress, who actually decide themselves that they're done with trying to have their baby at home and they want to move into hospital for whatever reason. So any transfer is always done with the consent of the woman. So we will always talk, we talk as well through the antenatal care period, that we will never secretly be sitting there worried or secretly thinking things. It's all out in the open, and we encourage women to be the same. And so if we're ever worried for the woman, we'll sort of say, look, we're kind of watching this. How are you feeling? And often she's going, oh my gosh, I know, I was thinking the same thing. And we talk about what we can try. And then often the women come to the decision to transfer around the same time as we kind of think, maybe we should chat about transfer. This is abnormal. And so if we think practically, basically the midwives or the woman identifies something that might warrant additional care, and then we talk about it amongst the midwives and the woman, and everybody in the room's usually involved. Whoever support person is there, the partner, the woman. We talk about what we're worried about, and then the woman gets to decide how she feels. How do you want to do this? Do you want to go now? Would you like to have a shower? Do you want something to eat first? Have you got your bag packed? It's not usually this really big emergency. And probably if I think back to our last transfer, Ashlee and I, it was an emergency and it was still very, very calm. The ambulance actually took about 45 minutes to get there. And during that time, we were talking to the woman, checking in on the woman, being there still as her midwives, waiting for transfer. So we call an ambulance, we phone the hospital that we're transferring to, which our clients are usually always booked into. We have the emergency equipment that we need to care for the woman in the interim while we're waiting. And then we go with the woman to hospital and stay with them until they've had their baby and everything's done. And we either bring them back home again or wait till they're settled in at the postnatal ward and head off after that. So a transfer is not the end of your journey with your midwife. The midwife actually comes with you and still provides support in the hospital. So we don't, some women are like, oh, I didn't get what I wanted. I didn't have my home birth. It's not a failed home birth. It's just timely and appropriate care based on the woman's needs. And so, yeah.
Excellent. Yeah, I agree completely. In my eyes, a transfer is a successful home birth. I mean, I don't see how you could possibly fail at birth. You can't.
There is no failure, and it just means that you're moving to the place that is now the safest place to be. And most of the time that is at home, and sometimes that involves transferring to hospital. There's nothing wrong with that. But I did get a question from a GP fairly recently that was sort of like, what would you do if someone had, a postpartum hemorrhage at home? And it felt like the presumption was that I was going to throw pixie dust at someone if they were bleeding at home. Like there was no understanding about the medical process. Okay. Sorry, I just got another one out of bed. Yes, buddy.
didn't know it when I was in the was a phone.
Yeah, I do feel like, just to carry on from what Ash was saying, that that there is, I suppose, misconception about what care is provided by midwives, because I think a lot of people have this understanding that home birth is this rogue, you know, underground system, but it's most certainly not. And thank you for explaining what you actually do. And this almost touches on the answer that you just gave anyway, but do you support a labour in a hospital if the pregnancy becomes higher risk and home birth is no longer an option?
Yeah. In fact, I have a client coming up that was never planning on birthing at home because of things that had happened in a previous birth. So sought my care for the continuity of care and my role as a support person in labour and birth.
And we and I talk to my clients too, because often they come and they're sort of like, I'm not sure if I want to have a home birth, so I don't know if I should book in, and I'm not sure what I should do. And I'll often say to them, you don't, when you're choosing a private midwife, you don't actually have to choose your place of birth yet. So you're basically, when you hire a private midwife, you're not hiring somebody for a home birth, you're just hiring a private midwife to be your carer. And then if you ultimately decide to birth at home or in hospital, you still have your private midwife. And that often makes people feel a lot easier, because they think, oh, I can't book a private midwife until I know exactly where I want to give birth, and I'm not sure about home birth yet. I need some more time to think about it. But if you wait and think about it and come back to your private midwife in 5 or 6 weeks, you might already be booked up. So yeah, I think it's important to realize that not all private midwives are home birth midwives either, and that we don't necessarily see ourselves as just home birth midwives. We just see ourselves as midwives that will care for you wherever you are.
Yeah, excellent response. I just had a quick look on the Facebook Live to see if there were any questions, and one of the questions was, is it safe to have a VBAC at home? So that's a vaginal birth after cesarean.
Yes. Yes, it is. So so all private midwives work under the Australian College of Midwives consultation and referral guidelines. So we call it the guidelines. And basically there's a collection of, I guess, complicating factors that they list out there, and things that we're required to consult and refer on with other healthcare providers. And having a scar on your uterus is one of those things. So it could be a scar from something else as well. And so we are required to consult with other healthcare providers about the care of this woman. But a lot of women who are plan VBACs at home, and we do them, there's obviously education that goes on. We're aware of when things can become complicated and then transfer in. The transfer rate for VBAC is slightly higher than the general transfer rate, and that's demonstrated also in a lot of VBAC research, that approximately 30% of women who are planning a VBAC at home will ultimately transfer into hospital for one reason or another. But just the act of planning a home birth actually increases your chances of vaginal birth up to about 95%. So even if you don't actually end up giving birth at home, the fact that you were planning one and you've got a private midwife means that your success rate is still way up in the 90s. So even if, you transfer in, which is, I think our tolerance for complexities at a home birth is a lot less for a client who is planning a VBAC, because we're hypervigilant to symptom, like signs and symptoms, that there's a potential complication from that. So yes, you can plan a VBAC at home, and there's just some paperwork that we have to fill out.
Always comes back to the paperwork.
Like you don't already have enough. We have a question here from Alyssa. Do you find it hard when not all private practice midwives have visiting rights in hospitals, so can't always act as a midwife in hospital?
It depends. So I actually chose not to get visiting rights at a local hospital because when you're working with visiting rights, obviously you're the main care provider for that woman when you move into hospital. There are some, and to me, that involves a lot of paperwork and a little bit of following the hospital. You come under the hospital staff requirements, then, you know, you're under their insurance and all that kind of stuff. And it's possible that your activity could be restricted a little bit by that. And I find that when I move into hospital with a woman, we're moving in because we actually need a higher level of care than what we can provide to them at home. And so I'm usually incredibly grateful for the skill and the skill of the hospital midwives. And we're moving in because that woman, something's happened to her that she's fallen out of our scope as private midwives attending women at home. So I personally don't particularly want visiting rights, but that has been challenging during COVID, where they're restricting support people, because then all of a sudden the private midwives are excluded from the rooms. I'm not sure. I think, Ashlee, were you pursuing visiting rights?
Yeah, so I'm looking at applying for visiting rights the next time that they advertise positions for that, because they do restrict the number of midwives that have that. With the idea, with Mel and I working together, if we did have clients that, you know, we did end up in a situation where medically they would require an induction or something like that, I would be able to then enter into the system with them to do that. And particularly for me, that comes as well around breech birth. So, you know, if you have a client at term who may or may not have chosen to have an ECV and try and change that position that the baby is in, and then they would like to pursue a breech birth. Obviously, sometimes you have undiagnosed breech births, but yeah, one of the things we know is that vaginal breech births are a completely safe option if you're in a place that has staff that are trained to do it, and facilities to manage any issues as they arise. So that would sort of cover then clients booked between both myself and Mel. And I'm hoping, because I attend births out west, I'm hoping to develop that sort of relationship out west as well in the future. But because I have that background of working in the hospital, it's a lot easier for me to sort of be able to function, even if I feel sort of conflicted, but I can sort of work with women a little bit easier in that, explaining what the hospital policies are, reasons for it, making sure that they have informed choices in that process.
And that would be really valuable to be able to offer to your women. You mentioned briefly about a breech vaginal birth. Is breech birth at home an option for women if they know about it, or could you potentially speak to an unknown breech birth at home?
So there's
Mel.
yeah, so surprise breaches, obviously we have to attend them at home because they're a surprise, and so a surprise breach isn't like, oh, the midwife missed it. What actually happens with these surprise breaches, you know, we are checking the position of a baby each time we visit a woman. So what usually happens is that you've seen the woman sometime that week that she goes into labor, felt that her baby's head down, and then when you arrive for the birth, you just make the assumption that the baby's still head down, because that's traditionally what happens. If it's head down 3 days ago, then you assume it's still head down when it's full term. So, and sometimes we attend women and they're in strong labor. So we don't do things like check the position of the baby and vaginal exams and all these things when we arrive. So that's why we get caught by surprise occasionally. So yes, I have had surprise breech at home. It was amazing. The woman was having her 5th baby, and yeah, literally just kind of looked, and I said to the other midwife, is that toes? And she goes, toes. And she just kind of left the room for a moment. And, you know, with breech births, sometimes the babies are a little surprised. So in your mind, you're thinking, okay, when the baby comes out, what might it need? So, you know, she just set up a little bit of resuscitation equipment just to prepare. The baby was beautiful and fine. And in those situations, there's no value to doing anything in particular. The baby's coming. If you can see the baby's bum, it's on its way. It's almost like you can see it's like you can see the baby's head. You wouldn't suddenly change plans because of that reason. So in that particular circumstance that I'm thinking of, I didn't say anything to the woman. She was on hands and knees. You know, you just wait. And then when I passed the baby through to her, I just said, your baby came bum first. She said, I thought it felt different. And that's as dramatic as it got. And, you know, and it was a surprise, but it all worked out really well. But with breech births, if you know that the baby is in a breech position, what we also know from research is that the best breech outcomes are with skilled clinicians who frequently see breeches and who can maneuver breeches if needed. So breech birth itself is not an emergency, just like birth is not an emergency. But occasionally, 10 to 15% of the time, we as midwives need to intervene in some way, even in a physiological birth. And that's the same with breeches. So if the breech is coming quite normally and fine, you actually have hands off and it's fine. It's when there's a complication with the breech that if you don't have a skilled clinician, the clinician can actually make things worse for the baby by what they do. If you put your hands on a baby incorrectly or turn it incorrectly or maneuver it incorrectly, you can actually damage the baby. And so that's the risk of having a breech baby at home, is that if your midwife isn't particularly skilled in the emergency maneuvers, you may actually be in an unsafer position than if you were in a hospital with a skilled clinician. So we have the benefit of having a breech clinic at one of our local hospitals. And so if we had a known breech, that would be our suggestion. And there's lots of things you can do to turn a breech as well if you want to, acupuncture and moxibustion and ECVs and all these things and spinning babies. So the preference is to try and get the baby head down and then obviously continue with a home birth. But most midwives won't knowingly attend breech at home.
Wow, very interesting. Thank you for answering that so well. And I love how you're able to draw upon all of the research when you answer your questions. Are there any more questions? Would you like to add in the chat box? I might have a quick look on the Facebook Live just to see if I've not missed any. Does gestational diabetes prevent you from having a vaginal birth? And are there tests in the last week of pregnancy to reassure mum that the placenta is still working really well?
Do you want me to answer this one?
Really?
Yeah.
Yeah.
Okay. And there's just one more question there too. Do you want to gestational diabetes, Ashlee, or do you want me to?
Sure. I just had a recent client. So yeah, the main issue with gestational diabetes is that if we have higher than normal circulating blood sugar levels, it means that babies can grow a little bit bigger than they otherwise would. And sometimes that can mean that the babies grow in a bit of a disproportionate way. So their shoulders are often a bit wider than they would otherwise. The guidelines were changed a few years ago so that when women were having the sugar drink and the blood tests in the hospital system, they changed the criteria for those. The World Health Organization recognised, so there's no actual clear consensus on what those blood test rules should be. And unfortunately, overnight, we went from about 5% of the population registering positive for gestational diabetes to around 30% of the population. What we are seeing now in the evidence is that it has cost the economy a lot of, like, millions of dollars in how we manage it, but we haven't actually improved outcomes for mothers or babies. One of the other things is, if you actually look at the World Health Organization guidelines, they say that they recommend induction between 38 and 39 weeks for type 1 and type 2 diabetic women, and all other women as normal. Unfortunately, in the hospital system, we see routine induction of labour for gestational diabetes, even if it's well controlled, and which the World Health Organization says that you should not treat them as being diabetic if there have been no abnormalities in their blood sugars, because if there's no abnormalities in their blood sugars, their baby is growing fine. And then even if you have needed to give it treatment, you've given that treatment and you've actually mitigated the risk by doing that treatment. So yeah, one of the things, so I actually took a particular client on late who was sort of caught out by these changes in blood sugars, kind of got labeled as gestational diabetes, but in ongoing monitoring, it was quite evident that actually she was not exhibiting any kind of insulin sensitivity or anything like that. So we were able to move through that, but she didn't receive very respectful care by the team that she saw at her particular hospital. One of the things that some of the hospitals have actually moved towards during COVID, because they didn't want women sitting inside the hospitals, is actually monitoring people's blood sugars at home. So we're sort of seeing more a trend in relation to the woman's diet and what they sort of normally are, and can be a little bit more accurate for us in picking up what their sugars are without necessarily having as quite high false positive rates. Yeah, I don't know if that kind of covers that, sort of, if that's what you wanted to know with that one. Yeah, so it's not a big no-no or anything like that. It's just more about weighing up, you know, what the blood sugar levels have been, what the risk is, and it always comes back to informed consent, making sure that women are having really good, detailed conversations with their midwife about this, so that they know what their choices are, and
there's a big difference. There's a big difference between controlled gestational diabetes and uncontrolled gestational diabetes. So even if the woman's been diagnosed with gestational diabetes, if it's been controlled with diet throughout the whole pregnancy, then you can, for all intents and purposes, consider that woman to not be diabetic through her pregnancy. If it's uncontrolled, that's a good reason to have a hospital birth and not have a home birth, because there is impact on the baby even postnatally, with the baby being able to manage its own blood sugar and the issues with balancing the woman's blood sugar in labour. But certainly controlled gestational diabetes, diet controlled gestational diabetes doesn't stop women from giving birth at home.
Great. Thank you. There was also, at the end of that question, is there tests in the last weeks of pregnancy to reassure mum that the placenta is still working really well?
Yeah. Ultrasound will tell you the blood flow through the placenta. Some people will check the size of the baby on an ultrasound, but that is not terribly accurate. So there's a 10% difference above or below the baby's actual weight. So if you've got a 4-kilo baby, or if they tell you have a 4-kilo baby, it could actually be 3.6 kilos on an ultrasound, or 4.4 kilos. So it's not an accurate way, but they can check blood flow through the placenta to tell you if the placenta is functioning well, and amniotic fluid and all that kind of stuff.
Excellent, thank you. How is a postpartum hemorrhage handled in a home birth environment?
So we take, there's a medication called syntocinon, which is artificial oxytocin. There's also sintometrin, which is a combination of syntocinon and ergometrin. We also have another medication which we could potentially use if it's not related to the contractibility of the uterus, which is called tranexamic acid. We have IV fluids and cannulation equipment, catheterization equipment as well. So during a PPH, so a postpartum hemorrhage is anything more than 500 mils. But what we notice at home is that women are usually not compromised by 500 mil loss. So we might not actually manage that unless the woman becomes symptomatic. Anything over 1,000 mils is considered quite a big postpartum hemorrhage. And so even if the woman's uncompromised, we would recommend the use of syntocinon as the first line management. And that's an intramuscular injection with a needle. That's very, very effective. I've only ever had to move on to the second line of medication about 3 times in 13 years. So syntocinon is incredibly effective because we haven't already given it to give birth, like for the woman to give birth to the placenta. So in hospital, they'll use syntocinon routinely to help with placental birth. But the problem is then if a woman has a postpartum hemorrhage after they've already used syntocinon, then they immediately have to move on to stronger medication to control that postpartum hemorrhage. Whereas at home, we just wait for the placenta to come as we waited for the baby. And so if the woman then bleeds after a physiological placental birth, then we can just give that single dose of syntocinon to stop the bleeding, and that's incredibly effective. Failing that, there's the use of IV fluids. You empty the bladder with a catheter, can give second line medication, and obviously we're planning to transfer. But where women are asymptomatic, so where their blood pressure and pulse and all that doesn't change, we might not necessarily intervene until the blood loss is a little bigger. So we've got all the same medication, yes. And obviously antenatally, we're also checking that the woman hasn't suddenly become anemic and making sure her iron levels are good and all that kind of stuff to prepare.
And you're also thinking about the reasons that people have a postpartum hemorrhage. You know, most often it's around people getting induced and having lots of oxytocin exposure during their labor, which basically makes their uterus relax after the baby is born. The other one is people pulling on placentas, often to get them out quite quickly, which can, you know, detach the placenta before your body is ready. My experience of postpartum hemorrhage in home birth is that they happen a lot less than in the hospital because you're leaving that birth process alone. But then, yes, we do have all of the equipment and all of the drugs and everything like that to be able to manage it the same way you would in a hospital if needed.
Excellent. A question from Kylie. Do you see advanced maternal age as a reason not to home birth?
No.
So some guidelines, you know, they're terribly restrictive. I think anybody over 35 is considered geriatric. It's the worst word ever. And so I've had clients, I've had 42-year-old client, I think 42-year-old was or maybe even older, quite old, much older clients, but I would consider their personal situation more so than their age. So I've met very unhealthy 27-year-olds whose bodies may be much older than their age. And I've met incredibly healthy 40-year-olds who are looking after themselves incredibly well. And so their actual physical body age is potentially much less than the number of years they've been on Earth. So I just consider their individual health rather than their specific age.
And the whole thing with with advanced maternal age is that if you look at the statistics, it's just very small per 1,000. The normal stillbirth rate, I think I put a post up on Facebook recently about it. It's like it goes from 1.1 to 2.1, and then in different age brackets. So it's not. It's just that as the pregnancy progresses, they have a slightly higher rate of stillbirth. Unfortunately, there isn't a lot of informed consent around that. Often the policies are just, you're this age, you get induced at this date, and people don't realize that they can sort of weigh up that risk of, if that's, particularly if there might have been a fertility journey towards getting that pregnancy, that risk might not be acceptable for them. But who are we to decide what risk is acceptable for them? They need to have that information so that they can make that choice themselves.
Yeah, absolutely. There's a question here from Carrie. Are home births still an option for mums with hypertension?
Depends what the cause of the hypertension is. So there is pregnancy-induced hypertension, and then so that depends on if it's controlled or if it's not, have looked after clients with pregnancy-induced hypertension who've still chosen to give birth at home. There is some placental risk with uncontrolled high blood pressure. If high blood pressure, though, is a result of the woman, like sort of a lifestyle blood pressure where it's potentially kind of, where the woman, has been living with it, then there might be other comorbidities that we have to consider as well. But high blood pressure can be a symptom of preeclampsia as well, which is definitely not a safe thing to do at home. So I guess it depends on if the blood pressure is controlled and what the cause is. You wouldn't really be able to decide that until you had a full picture of the woman's well-being and the reason for the high blood pressure.
Yeah, so you wouldn't say somebody with hypertension alone on its own would be a cause to not have a home birth. There are just many other factors to consider. Yeah,
it depends on what like if it's been ongoing, if the woman's medicated, how high it is. There's a lot of factors to consider.
Bibi asked if we touched base about twins. We did discuss that at the start, and can't have a private midwife. I suppose you could have a private midwife that would be happy to support you with the hospital birth. Would that be correct?
I love supporting twins. I've got a little soft spot for it. I would happily support people having twins in collaboration, with a hospital, and be able to be that advocate for them in that birth space. I just wouldn't probably plan to have them at home.
Yeah. And we have cared for, in the last 2 years, we've cared for 4 sets of twins, all planning hospital births, but certainly you can have a private midwife, but we wouldn't recommend doing it at home.
Yeah. There's a question from Joy that seems very specific. I'll just read it out. What are the chances of scar rupture during an induction with 1 previous cesarean and 21 months between births? Just to not be giving, obviously, medical advice, I might just generalize the question a little bit, and, just ask, what are the chances of a uterine scar rupturing?
So without induction, the rate of rupture for women who've got a scar on their uterus is about 0.7 to 0.9%. It's actually quite similar regardless of whether the woman's had 1 or more cesarean sections. The highest rate of rupture is for women who are undergoing any induction procedures at all. So even just having the cervical gel, a Foley's balloon, anything that you attempt to do to induce labour for a woman planning a VBAC roughly doubles the chance of rupture. When I say doubles, I don't mean like there's a 50% chance. It's like it goes up to something like 1.7 to 1.9% rupture rate of all women. So if you had 100 women planning VBAC and you induce them all, 1.7 to 1.9 of them would have a uterine rupture. If you didn't induce them and waited for everyone to go into labour, the rupture rate is about 0.7 to 0.9, and that's, So as a general rule, though, hospitals are reluctant to induce women who've had previous cesarean. So because induction itself is a risk for rupture. So even a woman having her very first induction actually has a uterine rupture rate of about 0.7% as well, even without a scar. So induction itself is a risk for rupture, and then that increases if you've already had a previous scar on your uterus.
Yeah, that is interesting about the risk of induction. And I think, I suppose it would come down to informed consent from the care provider to let women know, because I'm not sure I was even aware of that. That is really interesting. I
think the highest statistic in any study was close, almost 3%, but that was like with a less than 12-month gap between the previous cesareans and multiple cesareans and stuff like that. So, overall, you are still talking about very small numbers.
Yeah. I think we've made perfect time because that is all of our questions and it's almost 8:30. So thank you so much. Was there anything that either of you wanted to add or to mention before we go?
Probably just, even if you don't want a home birth, get yourself a private midwife, because they're valuable regardless of where you choose to give birth.
Yeah, I totally agree. Awesome. Lots of people saying thank you, very informative. Before we go, I have to share my screen so that you can get your phones ready and scan the QR code for the Active Truth voucher. If I can find how to do this, here we go. There you go. So if you scan the QR code, it should take you to the website and add a $50 credit to the cart. So go ahead and do that.
Even I'm doing it. How exciting.
They're so generous, offering all of the webinar participants a voucher. So thank you, everyone. Just one final thing to mention is that our incredible raffle will be drawn tomorrow. So go online now on the website and purchase your raffle tickets. They're $20 each, and there are some amazing prize packs each. I think there's 3 each worth $1,500 with some seriously amazing prizes. So get in there now while you can. And thank you all. I'm going to close off now and have a beautiful night. And thank you to our volunteer midwives, Ash and Mel.
Thank you.
Thanks a lot.
Thanks, guys.
End this. Stop live stream. All right. Bye.
Bye.